All right. Well, I've got 3 minutes past, so thank you all for being prompt and for joining us here on the fourth of our webinar series. We appreciate all of you that have attended before, and I know this one's a highlight to cap it because we get to talk to my former colleague and friend Brad Tinnermon from Kaiser, and Spencer Alley is joining us as well. So we've gone through a journey here of four webinars that are all out on the Asperian website, so you guys can go back and look at. The first one was about what are we talking about when we're talking about AI and ML in healthcare, and then we went into how we're applying machine learning models specifically around prediction of overturning denials in our second one. Our third one was how we're using our platform called DocIQ to use large language models to automate the extraction of information out of medical records to help the appeal process and denials. And then we're capping it off here with, as I said, my former colleague and friend Brad Tinnerman at Kaiser, who will give us a perspective on what he's seeing in the market more broadly, trends, and those kind of things. So a reminder, we're recording this webinar. It will be out on our website as well. And then furthermore, for those of you who are attending HFMA annual here at the end of June, Brad and a couple other industry executives will also be joining us in a panel presentation on Tuesday morning. So if you guys happen to be in Vegas and attending HFMA, come join us Tuesday morning. I think it's at 9:45. We'll do kind of a fireside chat and get broad perspectives from everyone on what they're seeing from AI and ML and denials and other. So with that, let's get started here. First off, I'm Jim Bonesuck. I'm the Chief Strategy Officer at Asperian. Got responsibility for M&A and product and the broader strategy of the business. Let me turn it over to my colleague Spencer and do a brief introduction.
Yeah, hey everyone, Spencer Alley. I'm the Chief AI Officer here at Asperian, and it's been a pleasure being on these recent webinars and looking forward to HFMA. I'll pass it over to you, Brad.
Hey guys, Brad Tinnermon. I'm the Senior Vice President of Finance Shared Services at Kaiser Permanente. I run the revenue cycle services at Kaiser.
Well, thanks, Brad, for joining us, and Spencer, as we conclude our four-part series here, our side gig. We're excited to have Brad. Brad, you and I have talked, but on our prior webinars, we discussed kind of the issues that are impacting the broader market. Everything from increased denials and staffing challenges and always a challenging reimbursement environment for providers. And I think we've always seen throughout our career kind of animosity between payers and providers and the battle that occurs between the two. It seems to be at a higher pitch than normal right now, especially around denials and the use of AI on the payer side to generate additional denials. I'm not sure that they're doing anything different. They're just doing it faster and more efficient. But, you've been in multiple environments, including Banner, and Kaiser's model is a bit unique in that payer, hospitals, and providers are all under one umbrella. Kind of give us your perspective on what you're seeing in the broader market today.
Yeah, I think you are feeling the pressure of payers being a little bit smarter now. Not all payers are created equal. Some of them are much more astute and effective in holding firm on the contracts and rules that they have in place, and others maybe just be a poor payer and they could be denying because of their lack of ability to execute. So I wouldn't put all payers in the same category, but I do think to have a great payer relationship, you do need to understand your contracts, have a strong contract management system, use payer report cards, really monitor what you're seeing from the payers and be thoughtful on what is within the rules of your contract and what isn't. Clearly in areas like Medicare Advantage, that's become a much more fevered pitch because of the growth of Medicare Advantage taking over more and more of the Medicare population. That's a payer mix shift to many people that has been subtle. We've gone over the last 10 years from 15% Medicare Advantage to I guess projected to be 55% at the end of the year. And that's no doubt moving from Medicare traditional, which paid in 14 days and was fairly easy to administer, to basically having more commercial payers that are a little bit stronger and more difficult in that space. So I do think that everyone's getting a little bit better. And if you're not focusing on the relationship, monitoring it, using heavy analytics, understanding the contracts, you're probably going to get left behind, and you're probably going to be frustrated by what the payers are doing. So it's definitely a new environment.
Yeah, are you seeing heavier investment on either side of your organization, payer provider, relative to the use of automation?
Oh, for sure. On both sides of our organization, on the physician side, on the provider side, we have all the way up to the very beginning of the clinical interaction is ambient listening, just listening to what's going on in the clinics and in the exam rooms, and pulling that data through and being able to prompt doctors right there within our clinic visits, all the way into very simple automation that we're doing throughout the revenue cycle on the payer side as well. Things in customer service, prompting customer service agents, reminding customer service agents of other needs of a patient, not only dealing with something that might be a balance, but also moving them back into the value-based care chain. So there's just endless places where you can apply AI, and certainly Kaiser, like everyone else, is looking at where do we apply that in an effective way that we can manage long term.
I guess picking up on that, Brad, I mean, so Aspirion focuses heavily on the kind of back end of the revenue cycle. You're in a kind of this unique position where you've got the Kaiser payer, but then you've also got the other entities that you deal with. When you think about revenue cycles specifically and AI use cases, are there any that either you guys are implementing or that you're considering or seeing in the market that you're particularly excited about?
Yeah, I think that there's really no limit to where you can apply it. If you think about most of the processes in revenue cycle, they're kind of an if-then, and you can use a technology to look at those things. Not every one of them, but a lot of them are from the beginning to end. And depending on what level of control you have of your data and availability of it, either real time or overnight, there's just not many places that you can't apply it from front to back. As you guys all know, like, we're under extreme pressure from labor. Like, we don't have enough, or it's becoming incredibly expensive. And when you do have it, it's inconsistent. So looking at these as options throughout the revenue cycle is very attractive. We've, of course, looked at it on the front end, one of those tough places in kind of the auth area to automate. We're looking at it in the CDI space. Of course, in the coding space, it's becoming more and more advanced. Many, many processes in the back end and the business office lend themselves pretty well to this type of work, down to credit balances and posting, all of those different areas. So there's such a rich environment for this, but we are careful of when and where we apply it to make sure that we don't create bigger messes for ourselves downstream as we do apply these things.
Yeah, and that's a great lead in. We in the past webinars, we've talked about a few different use cases, as Jim talked about, using the scoring or selection models, applying large language models. But the framework we've been thinking about is, okay, you need the use cases, you need the actual data to address the use cases, you need a platform to build the models and apply them in production, and then you need the actual talent to effectively execute all of that. We talked about staffing shortages and so on, and ultimately all that comes down to kind of a build by partner type of framework. As you think through some of those use cases that you touched on, how are you thinking about, does Kaiser and your team have the right pieces of the puzzle, or are you going out and finding that at other places?
Yeah, I mean, I work with a lot of really smart people at Kaiser that would love to build internally, and the reality is sometimes we're just not quite ready to do that, and it is effective to look at a partner. But as we look at these different areas where we can apply AI, automation, whatever you may want to call it, we use a bit of a framework to get there on what we may want to do, where, how, and why, what would we be buying. The first thing that we tried to do both at Banner and at Kaiser is first get the set of definitions of what type of automation are you talking about? Because there's a pretty big spectrum of automation, from keystroke emulation all the way up to true machine learning, and better understanding what type of automation are you actually talking about. if you're in any state of flux in your technology, you need to look at where you're applying AI. Do you apply it directly to a host system? Do you partner with a host system? Do you apply it to active live data? Do you apply it to resting data? So we definitely are thoughtful in that space. But then, of course, once you build it, you have to care and feed for it, and you have to make sure it's maintained. If anything breaks, then who's responsible for it? So when we look at building something, and we look at an external partner, are we just asking them to buy it and then we maintain it? Or are we asking for a subscription and then we buy it from them and they maintain it long term? So there's a bit of a structure we go through of what kind of automation are we talking about? Are we putting it on active data? Are we putting it on resting data? And what sort of subscription model are we looking at to apply it to? Because as you know, if we start running thousands and thousands of accounts through an automation and we've gotten rid of that staff, what's the backup plan?
Right.
So if it's internal, it's all on you to figure out how to recover from an event. If you've got a subscription, then you're going to be relying on the service level agreement of the vendor that you chose to do that. And of course, with moving environments, you got to be very thoughtful of your technology changes. And if you build stuff in house, or is your team completely tied into the core IT groups to deal with changes, and the same with your external vendors. So there's a lot to think about here, but I think structuring your thought process on definitions, where you're applying it, and then the model that you're using once the application is up should become standard for people as they think through this process.
Yeah, that makes a lot of sense. I guess just to double click on a couple of those things, we kind of differentiated in our use cases between more what I'll call traditional machine learning, even though that's still relatively new and there's still so much opportunity for that, versus some of the large language model stuff that's emerging over the past 18 months or so, and how that large language model capability is really starting to unlock new use cases in terms of extracting information from medical records or other things. Is the framework that you just talked through as you think about your use cases, is that different for those, or is it kind of the same regardless of if you're using something more cutting edge or something that's more well understood?
I think we're focused more on what I'll call resting data as opposed to live data right now, because it's more controllable and predictable to us. There's a lot of hype around getting stuff in a real-time data flow, particularly in the front end and the patient access areas. But that's a really, really difficult application location for AI. But resting data, you can rely on an overnight process. You can audit it before it gets acted upon, and you're not relying on it driving the work stream in an urgent way, or doesn't have an urgent need. And so anything that we're extracting data from a medical record, notes, contracts, whatever it may be, if it's resting data, we can pull that data, run it through whatever algorithm we have, add new data, push it back to our systems, and move on from there from a workflow perspective. So I'm much more interested in that space now because it feels safer and more stable to me. Although I think it is exciting in the areas that we can go as our IT systems become more stable and we're more comfortable with the reliability of a real-time type AI.
Yeah, that makes a lot of sense.
Hey, Spencer, I failed to do my job and say that please enter questions as you have them, and as we have time at the end, we will get to those questions. But in that light, a question was posed, which I think is pertinent to this discussion. Can you define the difference? We did it in our first webinar, but for those who weren't there, let us do that real quick. Spencer, as the Chief AI Officer, is classically trained in these technologies, but just define the difference between machine learning and the large language AI products is the question.
Yeah, that's a good question. I mean, the short answer is machine learning is a broad category, and large language models are kind of the newest capability within that broad category. But I think when we're talking about it, and the way we differentiated in our second versus our third webinar, is the more traditional machine learning is going to be things like regression or classification, where you're taking some data and you're predicting kind of a discrete outcome, like, is this account likely to would an appeal be likely to overturn this account or not, would be one example. And that, there are lots of different use cases for more traditional machine learning. Large language models are really focused more on specifically natural language and either extracting information from that natural language or generating text. So think ChatGPT or some of the other, of those kind of variety of models that have popped up recently. And that is effectively a kind of a step change in capability around dealing with natural language. So hopefully that clarifies a little bit when we talk about that.
Yes, and I'll even highlight, so summarizing the webinars we've done, so specifically we're using the machine learning predictive models around how to prioritize accounts for the most likely to be, overturned or resolved. And you can think about that even in patient balances. That's been done for some period of time, but using those models to say, what are the characteristics of this account? And if I have 100 accounts, in which order do I work those 100 accounts? Highest priority. So those are the kind of those traditional, as Spencer said, machine learning models. The newer large language models, as Spencer pointed out, is able to take unstructured text loaded into these large language models and query it or pull out pertinent information, understanding the relevance of the words within the text to do some kind of generative output, create an appeal letter based off evidence of the medical record is what is the use case we're doing now. So how do you help speed along the process through which a coder or a clinician, in our case, an attorney, reviews up to a 2,000-page medical record and pulls out the pertinent information to justify back to the payer why it was that complex of a case or should have been paid inpatient. The DRG shouldn't have been downgraded. Those types of things are being used and are being enabled through large language model usage today, which is as Spencer said, it is a step change in just technical capabilities, and it's evolving really fast. So keeping up with it is a Spencer's full-time job. But with an entire team that are dedicated to that full-time job.
In addition to webinars, it's my other full-time job.
Yes, your side gig, webinars and podcasts and other, really appreciate that. All right, hey Brad. So news relatively recent about Kaiser and Geisinger pairing together to create Risant, if I'm saying that right, Health. Two very respected organizations, both clinically and operationally and in their markets, that kind of thing. Yeah, I'm sure there are details you can't share, but as you think about the compare and contrast between those two, I assume Geisinger more banner-like in your compare, but just give us your perspective from an RCM operations. What are the differences and the different challenges that these two organizations are kind of facing, and how you think about those two organizations?
Yeah, first of all, we're really excited about that relationship. So I haven't gotten deep into the Geisinger relationship personally yet, but a lot of respect for that group and the leadership there. Looking forward to working closer with them. I will say my perception of the difference between Kaiser and Geisinger is based on my experience running Banner. So Banner was a typical health system, a fee-for-service health system. I believe Kaiser or Geisinger is as well. The big difference between the two organizations, obviously, Kaiser is a payer and a provider. They are separate legal entities, but we certainly take into account our payer relationship much more deliberately in the revenue cycle than you may if you're a strict fee-for-service provider. And what I mean by that is we run a value-based care organization, and the whole model around value-based care is around making sure you have access to care and you're not creating friction for our members to receive that care. We also need to capture acuity much beyond the reimbursement space. That is important for us to drive value-based care decisions. So we do create, I'll say, different processes and workflows within our revenue cycle to make it more value-based care friendly in a lot of different areas. I will say, like, for instance, when I first joined Kaiser, I was doing tours and going to hospitals and clinics, went into one of the emergency departments, and the typical process of triaging a patient and determining if they're emergent or urgent isn't near as apparent in a Kaiser facility. And they do have very distinct urgent care beds within an emergency department, which is very unusual. And my questions were, well, if they're urgent and not emergent, why don't you move them to an urgent care center? And the point is, at Kaiser, you want to care for a patient as quickly as possible, and you don't want to take the chance of them not receiving care and then their health degrading. So if they do come in the emergency department, regardless if they're emergent or urgent, they're going to care for them, and they will make sure that they get everything they need before they walk out, which is very different than the conversations you might have in a typical revenue cycle. There are also a lot of things that we capture around acuity that do not drive reimbursement, but they're very helpful for follow-up visits and for the physicians that are within the value-based care chain. So we do have to look at our edits and our captures very, very differently than you may in a typical fee-for-service. We do have a very large fee-for-service business. We have a lot of people that use our network that are non-Kaiser members. So we have to follow all the typical rules and typical processes that you have in a fee-for-service revenue cycle. We fortunately or unfortunately don't have contracts with payers. So if someone comes in our network, they're all out of network. So that creates its own level of challenges. We are across the country. We're large from a volume perspective. We do, I think it's upwards of 115 million encounters a year, which is just off the charts from anywhere else I've ever been. So there's just a massive amount of volume that we're running through this organization. So in the small accounts matter to us because that's where all the gold is from a value-based care standpoint. Those are where all the acuity is captured in those accounts. So we can't do the typical stratification or prioritization either. So I'd say they're pretty different with an underpinnings that are still similar.
Do you think there's, as I look at it, do you think there's lessons that can be brought from Kaiser and how you think about it more holistically to like a Geisinger or any other fee-for-service world? I mean, it seems to me that some of the conflict is the imbalance of information between the two organizations being payers and providers, and that the payers see it at the claim level kind of across any environment in which care was delivered, whereas the provider has the underlying detail to justify why that claim was created.
Yeah.
It seems that the friction is created because I, payer, would like to see that detailed level of information to say that it was right or to get the acuity level correct. And we get this like, all right, we'll deny it to get it, or we'll request it, or we'll audit it and get it. Some level of sharing across that would seemingly help. What's your perspective on that, since you're seeing it from that inside view?
For sure. I mean, my interest in this space started at Banner. Banner owns health plans. We had a Banner Aetna plan that we were very tightly wound with. And that's where my first interest started with payer-provider collaboration and what drove me towards better understanding what Kaiser does. But stepping up a little bit, if you're a health system from a strategic standpoint, you certainly want to control a population of people that may come to your organization and possibly lock your competitors out of that population. You also have pressures from payers that are, as we already stated, become increasingly difficult. So many health systems, including Geisinger, Banner, many others across the United States, have started deeper relationships with payers or being their own payer. They've launched and created their own payer for Medicare Advantage, commercial, whatever it may be. That enters into a completely different dimension that you need to be very thoughtful of, depending on if you're a risk-adjusted payer or you're just a typical commercial payer. You need to start thinking about member retention in a way that you haven't before. You need to start thinking about risk adjustment in a way that you never have before. And of course, member retention is the key to this game. Your top line revenue is that insurance premium. It's no longer your volume that you have running through your organization. So retaining and growing your membership base is incredibly important. Breaking down the walls between eligibility, being able to look into those systems and see, are they actually eligible right now today without having to use a third party? Looking where they are in their copay or deductible and knowing where they are right now collapsing customer service units where you're dealing with a patient's value-based care opportunity along with the balances they may owe. So you're not separating the payer and provider customer service. EOBs and statements can be pulled together into a single product as well. So it doesn't look like mom and dad disagree and you don't know which one to listen to or talk to. So there's a lot of places where you can break down the walls between the payer and the provider. Obviously, still needs to be a separation of church and state there, but there's certainly data that you should be able to share real time to make that member experience much, much stronger. And of course, the acuity capture from a risk adjustment standpoint is very important to one of those organizations.
Interesting. Yeah. Now, it'll be interesting to see how you guys can leverage the workings of both, like I said, Geisinger and Kaiser. Along those same lines, I should say, I was fortunate enough while at Deloitte to work on the Kaiser Health Connect project, which was the rollout of Epic at Kaiser. You probably say there are still holes in that as it continues to evolve, but Epic is a juggernaut, and that it is controlling much of the market, and Kaiser and Geisinger are both Epic shops. And I know they continue to innovate, and we applaud them for that. And I personally think they're doing a pretty amazing job. And they're announcing payer provider portals now, and some level of use of AI embedded within that portal. You're close to it. What are your thoughts on, kind of how that's evolving, how that technology is being deployed, what they're thinking about, how it may impact you guys both there and then Geisinger in the future? What are your thoughts there?
Obviously, it's an amazing company. On a side note, I can get a little worried when someone gets such a large market share. That if something does happen to that organization, what does it do to U.S. healthcare? But that's a whole separate conversation. I wish we had a little more parity in our technology vendors in the United States healthcare. Regardless, I have spent a lot more time in the Epic environment and with the Epic teams since I joined Kaiser. I hadn't used Epic in 6 or 7 years prior, going to Banner, which is a Cerner shop. So I have a pretty good comparison of the two. I think Cerner will also head this direction and payer provider for sure. But Epic's incredibly impressive with what they've done with their platforms over the last few years and the investment they've made in AI. But without a doubt, any time that you can break down the walls between what did I buy from an insurance plan and how did that adjudicate to reduce the confusion of consumers, I think is fantastic, without a doubt. There's so many people that buy insurance and don't completely understand what they purchased. There's certainly an entitlement mentality around healthcare in the United States, in that education process of being able to find that information quickly on your own, I think is important in helping people understand that neither the insurance company or the provider are the evil empire that's trying to make your life difficult. We are very much trying to work together and having technologies that help us collaborate, I think will improve everyone's experience.
Go ahead.
Yeah, I was going to add, so on, staying on Epic, they've made some announcements about integrating AI capabilities into the product. For any of the use cases that you guys are thinking about, are those product features ones that you're excited about, or just how do you think about kind of AI enablement through Epic or Cerner, the core platforms themselves?
I think there's some positives and negatives. I mean, I always appreciate the creativity and the vigor of third parties being able to figure things out that large organizations can't. I will say when you're applying things directly in workflow as opposed to resting data, of course, I get a little nervous. And who has a stable host system? Like, we're always messing with it. We're always upgrading. We're always consolidating, upgrading, whatever it may be. So in some cases, is it ever a good time to apply directly into your host system? I mean, I'm being a little facetious there, but we're going through our own instance simplification right now. So there's all these what look like fantastic things we want to consider, but when do we consider them? Because we're on an unstable environment. So working in the space where you've got resting data is a little more attractive right now until we can get, if we ever get to what I would consider a stable host system environment. But I do think that they've got a number of things that are going to be very helpful along the way for those that are in a stable environment. Maybe smaller environments are quicker and easier to deploy. We're just such a big organization. We're trying to keep things standard, and being able to roll something like that out across all of our markets is just a little unruly. So in some cases, you get envious of people that are a little more small and nimble to be able to consider these things. But again, they're an exciting organization doing a lot of great things. I wouldn't say we're in the greatest position to be able to use all of those things right now.
Yeah, that makes sense. I mean, my observation across industries is the LLM enabled feature sets are just going to become embedded everywhere. I mean, they already are in productivity tools and things we use day to day on our phones. So, it seems like the beginning of a journey that, will roll out eventually.
Sure.
How do you, staying on, speaking of vendors, so you mentioned earlier, and we talked about you kind of look at your decision-making criteria around who do you partner with and those kind of things. As I think you stated before, sometimes I want to pay for an outcome, right? I want you to own and deliver me a result versus I'm going to take either the technology and manage it myself. Are there places where that makes more sense to you, or you weigh those things differently as you think about, how you do it yourself or partner with somebody to do it for you? I know you have a kind of a unique perspective on vendors and partners. You share some of that with us?
Yeah, sure. I mean, I always encourage my team to look at buy, build, or partner any part of our revenue cycle. What are our core competencies? What are we good at? What does the environment allow for? Again, if we have a stable environment or not, are we going through a change? There's that decision that you always have to make of a buy, build, or partner. I do hear a lot of vendors that talk to me about their AI capabilities as a service vendor, which I think is great. That just means that their product should be cheaper and they should have a better margin. But that's not why I'm buying it. I'm glad that you're investing in that space. And then there's, of course, vendors that are selling me AI to be able to use within my workflow. Two very, very different conversations. But again, I always look at buy, build, or partner. What is our core competency? Where are we from a stability standpoint? Maybe we want to apply something for a number of years until our systems become more stable. Maybe we outsource it temporarily and move it back in after we get better at it, or we can build it in-house. Our internal AI team, I would say, is incredibly talented, but we have such a broad business that we're running, payer, provider, and then all the different parts of the payer and provider, to find subject matter experts that understand the data structure and can apply something gives you a much longer runway. So they could figure it out, and they would figure it out over time. And it may be cheaper over time, but their learning curve to apply in our particular small niche areas is so high. To look external at a company that knows those particular workflows really, really well and that data structure really, really well, it's just a faster path to getting an answer quickly. And if we want to go back and retool it in-house later, great. But usually the internal discussion has a much longer runway than an external vendor, at least right now in this developing and growing environment that we're in.
Yeah, no, I think it is incumbent upon us as partners to provider organizations to invest on their behalf. To your point, yes, it's good business sense to become more efficient, to become more accurate, to deliver a better product. Should always be evolving in that way. But as I look at it, to your point, there's so many competing priorities within your organization. I mean, you're talking about clinical workflows and you're talking about, to your point, scheduling optimization and chatbots and you've got the provider and the payer and you've got the hospital side, all competing for resources. And do you have, the competency and the commitment and the capital to go, invest in those things? You can think about them, in a vacuum. Yeah, to your point, they could totally solve it if they had everything blocked out in time to do it. But when you start to stack rank those things, I think that's where we see challenges, and we say, all right, we're delivering a service. We should be investing in this technology to make our service and solution and output better. How do we do it? And so in that case, we invested in a company that we own that has 9 PhD data scientists and 12 machine learning engineers, and Spencer runs them. We've got our own platform, and we're doing that development on behalf of our provider organizations, which I think is important. And to your point, it's not for all. Some may do it internally, and that's great. And we'd love to be helpful in that way. And then others just want us to produce an outcome, overturn that denial, whatever the case may be. So as you think about looking forward in AI and healthcare and some of the challenges that are facing Kaiser and the broader organization, kind of broadly, if you were to impart some advice to the broader market, what would you give them?
Yeah, I don't think we're unique in that we have constraints around labor, and then of course the increasing cost of labor, and then the inherent inconsistency with labor. I don't think we're any different than a lot of organizations that still have a very labor intensive process that we're working through. So having said that, we also have a lot of union relationships, which creates some rigidity in our processes and our ability to make changes to some of our workflow. So I think any place where you can take out variation and reduce cost, we have to do that as good stewards of the organizations we work for. And the most obvious places to do that are where you have inconsistent or high expense labor. So you can look just about anywhere you want across the revenue cycle. And the advice goes back to what we talked about when we started is be thoughtful about where you're applying it and how you're applying it and what are you buying. So are you doing resting data? Are you doing live data? Do you understand the definitions of the type of AI that you're buying? So everyone really understands, what is this AI doing for us? And then how does it get maintained? Even more important, once you get a cool change in place and you've created some value and you're proud of it, how do you maintain that? Because it's a living, breathing environment. Your technology is always changing, workflow is changing. And if it breaks or short circuits, you could be in a world of hurt if you don't put in place an ability or a way to disaster recover from it or fix it very, very, very quickly. So be thoughtful, and just like you do in any other part of the revenue cycle, is define it, understand what you're buying, and then of course buy, build, or partner when you look at those things.
I love it. I love it. Spencer, any final questions or thoughts?
I guess just at a high level, touched on kind of these use cases in the journey as you think about the medium to long term, in whether it's Kaiser or the broader industry. What is your level of optimism around AI and like the ability for that to really change patient experience or anything in kind of healthcare more broadly? Does it feel like we're really entering something different, or does it feel like we're just kind of on the continuous path that we've been on, throughout your career?
Yeah, the patient experience is an interesting one, because I think we'll probably enter that space last, or the halo effect of having a cleaner, more predictable process will generate a better patient experience. But I'm already seeing a lot of it. I mean, it's not that we haven't been doing automation for 20 plus years. We're just getting more savvy at it and creating more robust tools that manage across different places that we would have never thought of before. I'm feeling things are moving from back to front. That's the way I'm looking at them. Definitely squarely in the middle revenue cycle and charge capture, CDI, and coding in this space. And we've done a lot in the back end right now. A little more hesitant on the front end because it is more of a real-time flow in that space, but incredibly optimistic. I don't think it's a how fast. So if you're not being thoughtful in this space, you're definitely going to get left behind fairly quickly. Of course, you don't want to place bets too quickly without understanding things, because you could then create a mess. So there is definitely a fine line here of making sure you understand what you're buying, how you're going to apply it, how do you maintain it, and not getting out over your skis just because it's a, the hot topic right now, so to speak.
Yep, absolutely.
All right, we got questions from the audience. Please, use the Q&A function to submit questions if you got them for Brad or Spencer. And one of the questions that came in, Spencer, you can elaborate on this, is can you explain how you would incorporate, how we are, I guess, incorporating the pair criteria into the AI process of using the medical record to create an appeal letter? We've been
Sure.
down.
Yeah. I can talk about how we think about that and where we're at kind of high level on our roadmap for that. So when we think about what LLMs are really unlocking, I mean, the simplest way to think about it is how it lets us programmatically extract information from unstructured text, as Jim said earlier. So then the question is, okay, what are the important pieces of unstructured text we need to look at? We talked about medical records. Clinical care guidelines is another big one, whether it's Interqual or Milliman or other payer policies that they have on their websites and their portals and so on is a big one. Managed care contracts is a big one. And you've got smaller ones like, appeal letters and other things, denial letters. But the full solution or the full kind of vision, I think, that we have and that the industry progresses and unlocks more and more of that information is pulling all of those pieces of information into the kind of workflow in a more automated way and more accurate way, right? So, in our journey, we've started with the medical records, we're moving on to clinical care guidelines and some of these others, but that's the process. And then for us, it's human in the loop. So we have our experts who do this manually today, and then we have our systems that have large language model prompts that will go in and extract relevant information, and then we enable our people to operate at the top of their license that way. So that's, I would say, how we're thinking about it at a high level.
Yeah, furthering on that, I think even very simply, if you think about in our world, 190, I could lose count, attorneys that we have working these high dollar clinical denials that require clinical validation, right? They require us pulling the medical record to respond to either a downgrade or a full denial of a claim we submitted. And the payer is saying, I don't agree with the level of complexity that you said it was. Okay, well, I'm not sure how you know that because you just have a claim form in front of you, but all right, you're using some rules to say that I disagree with that. And there are, how do we practice good medicine care guidelines that are very well defined by, as he said, Milliman and Interqual. So that's one set of rules we got to consider. Our managed care agreement, our agreement between them, payer, provider, also dictates that relationship. And then, that managed care agreement undoubtedly says and refer to the payer policies, published whenever on our website as we see fit. So you got those three pieces. And then we've got what happened, right? The medical record. So as Spencer said, we've got people today getting that letter that says, I deny this because I disagree with the level of complexity that you submitted it as. And we're saying, all right, now I got to go fish through, again, 500, 2,000 page medical record and find where in an easy use case that we're doing today is where sepsis was evident in there to create complexity. And we're pulling out that evidence and citing it from the medical record, comparing it against what is good practice of medicine that suggests when sepsis creates complexity, and are there any payer policies also relevant to that creation of that appeal letter. So all of those things get structured, if you will, into the database or the large language model, and then those pieces of information can be referenced and pulled to then create that appeal letter. So that's how we're working through it today, and continue to evolve because there's tons of payer policies and everyone's got a managed care agreement and you've got different care guidelines for different sets of diseases and all of that. So it's a very complex kind of thing to pull those pieces together, but it's logical in its structuring when you think about it like that. I'm gonna look, no further questions right now. So Brad, thank you. as always, for spending time and sharing wisdom with us and the broader market. It's always fun. It's a pleasure. I look forward to seeing you in several weeks in Vegas when we do this live with some other folks. It'll be fun. Spencer will be there as well. So we're looking forward to seeing everyone at HFMA. And we appreciate you guys attending today. And if there are further questions, please feel free to send them to us. We'd love to help. These will be recorded, as I said, they're on our website out at Asperian under the resources tab. So if you get a chance, check out the prior ones if you haven't seen them. And again, thank you, Brad. Before we close, there will be a survey that pops up at the end of the webinar. So please let us know other topics, what else we can do to share information with the broader community. We'd love it. Thank you all.
Thanks, everyone. Thanks, Brad.